Good afternoon and welcome to today's SAMHSA sponsored webinar titled The Living Room, Leveraging the Peer Workforce in Crisis Stabilization on behalf of the National Council for Mental Wellbeing. Today's presentation will be recorded and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC icon at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who should be seen spotlit on your screen. During the presentation, please add your questions and comments in the chat box, and questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends today, a brief survey will show in your browser. Please take a few moments to complete that for us. Thank you again for joining us, and we'll begin our presentation.
Hi, everyone. Thank you so much for being here today. My name is Courtney Lavelle, and I am the Director of Practice Improvement and Consulting at the National Council for Mental Wellbeing. I work specifically in the public health and equity practice area, and I am really grateful to be here today. I've spent the last 15 years in the substance use and mental health spaces and focusing for probably the last 10 years or so on peer work. So I'm really grateful to be able to talk to you all a bit about peers and the role that they play in the crisis workspace. But as I was sitting here preparing to do this webinar today, I was really struck looking at the presenters, my co-presenters. I was struck by the memory of a 19-year-old version of myself who was struggling immensely with my opioid use disorder and my untreated complex trauma. I was suffering. I was in despair. I felt hopeless. I felt like I was not going to be able to heal and recover from my active addiction and from my mental health challenges. And at just 19 years old, I found myself really struggling with how to move forward. And I can remember so clearly February 8th, 2008, really hitting my bottom, hitting a wall, and not knowing where to go for help. And we didn't have resources like this 16, 17 years ago. We didn't have living room models. We didn't have safe spaces where someone could go in those moments. And at just 19 years old, I gave up. And I was driving my car and couldn't go back home. I had really damaged relationships with my family and friends because of my suffering. And I gave up. I found myself on the side of a road in the Capital District of upstate New York and decided to end my life by overdose. And because of my higher power, something beyond my control, I didn't die that day. And I was one of the lucky ones, one of the fortunate ones who was then able to get treatment, to get care, and to get the help that I so desperately needed at that time. But what if? And that is what I'm so struck by today. What if there were resources like this then? And what about all of the other versions of me that are out there right now struggling with their substance use, struggling with their mental health challenges, who are giving up, who are so lost, who feel so hopeless and don't know where to go? For me, that's why we do this work. That's why I do this work. That's why I'm here today. And that's why I am so incredibly grateful for all of you out there deciding to join this webinar today, getting up every single day and going to work to do this work, because there are people who desperately need these services, who desperately need this support. Today, we have two other presenters who are in that very community that I was just describing, who are providing these life-saving services today in that community. And potentially hearing them share the work that they do, maybe they'll inspire you all, if you're not already doing this work, to expand your work, to start these models where you live, because it is so desperately needed. But I'm on this call not to talk about that. I'm on this call today to talk about the role that peers play in all of this. And I guess the better way to explain, how leveraging peers in the crisis workforce is helpful is to first start with an overview of what peers even are. To me, peers are the mortar between the bricks. They are the golden thread woven through clinical and community-based services. Peers are the solid foundation for so many as they begin their journey of healing and health and recovery. When I first started doing work as a peer myself, as a peer trainer, I was first exposed to the concept of peer work as peer recovery coaches. That was the term we used. We still use that term in some parts of the country today, but it's less common now. But they're recovery coaches. And that term was coined off of the concept of a horse and buggy carriage, a coach. And the very first definition of the word coach, to coach, verb form for that horse and buggy, was to convey a person of value from where he or she was to where he or she wanted to be. So to coach was to convey a person of value from where he or she was to where he or she or they wanted to be. And that still rings true for me. Years later, doing this work, that is what peers do. They look to the client, the consumer, the recovery, whatever term you want to use, the other human who's trying to engage in some sort of service. They look at them and they see their worth innately because they know, they understand, they have shared experiences, shared struggle, and shared hope for a future. So they innately see the worth of that person and they walk alongside them to get to wherever it is that that person wants to go. And I'm going to talk a little bit more about those principles as I continue on. But that is what peers bring to crisis work, is this additional golden thread of support and care that can be woven throughout all of the other services that crisis centers, living room models offer throughout treatment. All right, so let's talk a little bit more about some of these principles. So principles of peer support, and this is as defined by SAMHSA and brass tacks. So number one, peer support is recovery oriented. What does that mean? Peer support operates under the principle of recovery oriented care, which emphasizes the potential for individuals to recover and to lead fulfilling lives regardless of mental health challenges or substance use disorder. It recognizes that recovery is a unique and personal journey and focuses on promoting empowerment, hope, and resilience. It's person-centered. Peer support is centered around the individual receiving the unique supports they need. Peer supporters aim to foster a sense of dignity, respect, empathy, and ensuring that support is tailored to the specific goals and aspirations of that individual. Peer support is voluntary. Peer support is based on the principle of voluntary participation. It respects the individual's autonomy and allows them to decide whether to engage in the support process. These principles ensure that individuals feel in control of their own recovery journey and have the freedom to make choices that align with their personal preferences and values. Peer support is relationship focused. Peer support places a strong emphasis on building trusting and authentic relationships between individuals receiving support and their peers. As I just described with that coaching definition, so much of peer services lives and breathes within that peer support that's formed between peers, that connection, that relationship, and that trust. Peer supporters serve as a role model, offering empathy, understanding, and shared experiences. Through those connections, individuals have the opportunity to feel heard, validated, supported, and it fosters a sense of belonging and community, which is so important for anybody who's going through any kind of crisis experience. Peer support is trauma informed. It recognizes the prevalence and impact of trauma on individuals' lives. It aims to create a safe and supportive environment that is sensitive to the potential triggers and needs of those who have experienced trauma. Peer support receives peer supporters themselves receive training and understanding of trauma dynamics, practice things like motivational interviewing, active listening skills, promote healing and resilience, and they take into account the unique experiences that each person has. Some of the barriers that peer supporters face, and this slide is really relevant to pretty much anyone in the behavioral health workforce at the moment, because there are a lot of challenges right now with just supporting our behavioral health workforce in general. But of course, peers are certainly not immune to that, and may even face some of these challenges even more so because they're a newer role, especially on the SUD side of things. The Foundation for Opioid Response Efforts did some qualitative and quantitative surveys of peers working around the country, and some of the common challenges you'll see on the screen: low pay, burnout, limited career advancement opportunities, but also lack of role clarity. So not really understanding the role of peers has been one of the biggest challenges that peers face. And hopefully things like this webinar and other trainings can help to change that. But the more solid of an understanding the rest of the team has about the role of a peer supporter, the better a peer supporter can be utilized within a space. And that is common across the board for all sorts of peers. So there's many different forms of peers because there are many different life experiences that individuals can have. So we have community health workers, peer recovery support specialists, and peer support staff. So we have mental health peers, SUD peers, and community health workers, and they're all very similar roles. Mental health peers have been around much longer than SUD peers, who have really only emerged in the last, I should say, emerged professionally as a professional role in the last decade and shorter. Although peer support on the SUD side of things has existed for a very long time through mutual aid 12-step groups. But they're all very similar. They're all rooted in carrying some form of living experience, all understand the impact of social determinants of health, all recognize the mind-body-spirit connection. They operate from that partnership, walk alongside perspective. The real difference is in their lived and living experience. And I didn't have these on the screen when I was just showing that, but this just shows the like Venn diagram of the similarities. They're mostly similar, with really the difference being in that lived experience and potentially where you're certified, through what certification or credentialing board, and maybe where you can be employed. Let's talk a little bit about the journey and the impact of having peers throughout any kind of service. So this is a sample participant journey put out from SAMHSA through their Peer Center of Excellence. And I want you to note in this, so this shows the trajectory of any, traditional treatment experience for an individual. The initial conversation, orientation on available services, regular support. What you see woven through here, although it's not a golden thread in this example, it's a green one. It's still the same concept. This golden/green thread is how it can look when you have peer services available within that treatment service. So we're talking about crisis services today. Really, these first 4 bullets are all potential crisis service touch points that peers can play an important role in. I mean, it's anything really in that pre-contemplative and contemplative stage of change. Those first 2 going into action, we have the potential to utilize peers to support individuals in those moments. And that is exactly what you'll find with the living room model. We are really leveraging peers here in a beautiful way to help move individuals who are coming in probably around contemplative into action and to feel cared for and supported and safe enough to start moving along that journey. So there's one really great tool out there that, well, there's many great tools out there, but there's a new tool out there that I really want to showcase and I want to offer to you all if you are an organization who is doing crisis work or considering expanding into crisis work, and you are considering integrating peers into those services, or you're considering just expanding. It's really important to gauge your overall organizational readiness to implement such services. As we've seen substance use peers start to expand pretty rapidly across the country because of a lot of new funding, we have really seen some struggles with organizations adopting peers and really supporting them so that they can thrive in these new roles. And because of that, we've started to see more resources be created, one of which I'll be sharing with you today. And that's something that was put out through the Peer Center of Excellence through SAMHSA, that National Council had played a large role in helping to create. And it's the Increasing Recovery Consciousness, Grounding Systems in Recovery. It has a framework, it has tools. The next few slides are going to be pieces that I pull out of that. But overall, a really great resource to gauge your organization, to assess your organization, to see how ready you are to integrate recovery consciousness into the work that you do, and then provide some resources and support to do that. So first, I want to show you this slide. This is the new framework, the Recovery Consciousness and Integration Continuum, or RCNIC for short. And it is teaching organizations to move from some of these beliefs that a lot of treatment was rooted in, how do I get somebody to be compliant in treatment, to this idea of how can I help you with your recovery today? How do I help you do whatever it is that you need to heal on your journey to get to wherever it is that you want to get to? Doesn't that sound a lot like that coaching definition I gave you before? And that's why peers can be so helpful in this. We're trying to help organizations gauge where they fall on this spectrum. How recovery aware are they as an organization as a whole? And how can they move to this more recovery centered, more recovery conscious organization? And peers are a huge role with any recovery conscious organization. They are involved, they are a service woven throughout treatment. They are not an add-on service, but a service that's really integrated. And in order to do this, in order to really conceptualize this framework and move your organization into recovery consciousness, one of the first steps is centering lived experience. So taking a moment to look at your organization that you're working at, or you're running, you're building, you're expanding, and really asking yourself, how deeply are we integrating and valuing lived experience in everything that we do? Is the work centered in lived experience? Because recovery-centered organizations are peer-led and they're peer-governed. They understand that recovery happens in the community and they connect the community. They rely on the community for warm handoffs, for integrating into their services. They support individuals in developing those social networks so that care can continue on from whatever that initial crisis service is through ongoing care and beyond. They are spaces in which it's safe for an individual to say what it is that they want out of their care, out of their treatment. They don't have to, that the individual seeking care doesn't need to conform to a set list of services, but can get support in whatever it is that they need in order to start their healing process. They play a strong role in advocacy with both of the systems and in communities, and they address issues of equity directly. If we can start to center lived experience in all of the work that we do, we start to value the perspective of the clients or consumers, recoveries, or individuals that we're serving, and we can uplift that voice, including hiring people with lived experience and putting them in positions where they can really be important roles within the care that we're providing. So we've talked a bit about this recovery consciousness framework. We've talked a bit about moving an organization from thinking about compliance with treatment to getting services that they believe that they need, that they are, that they need in order to heal. And then we've talked about, in order to do that, we really need to create organizations that center lived experience. They center peers, they center the individuals that they're trying to serve. In doing all of this, we are ideally creating a recovery-oriented system of care, or a ROSC. So let's talk a little bit more about a ROSC. So a ROSC is defined as a coordinated network of community-based services and supports that is person-centered and builds on the strengths and resilience of individuals, families, and communities to achieve improved health, wellness, and quality of life for those who are at risk for mental health and substance use problems. It includes clinical services, recovery supports at each point throughout the continuum of care. Under the ROSC model, there are several key principles that guide systems planning for essential services. So prevention, crisis intervention, treatment, case management, social services. The idea is to ensure that effective, relevant, well-coordinated services are easily accessible within the communities themselves, that these services are where people are at, that they meet people truly where they're at within their own community. The ROSC model reorients systems, which is fundamental work that is so needed right now. Using these models, state agencies designed and fund services to meet the needs of diverse populations, decreasing fragmentation and improving intra-agency coordination in the process. Combined, models like this help systems to be more efficient and effective in achieving really clinical and service outcomes. The ROSC model helps prepare individuals for providing that person-centered care that we're talking about today. If we can integrate our organizations into this more recovery conscious framework, we are building a recovery-oriented system of care, which helps improve the outcomes for the individuals who we're seeing in our crisis centers and in our organizations. Just a couple more slides on ROSC. So the principles of recovery-oriented systems of care, really, recovery is emerging from hope and gratitude. It's understanding that in order for individuals to heal, they need to believe that healing is possible. For myself, as I explained earlier, when I entered into recovery, at the very end of my active addiction, my untreated trauma, I was completely hopeless. I didn't believe that hope and healing was possible for me. And it took me being exposed to other individuals who had similar experiences as my own, who were healing and who were doing more than healing, but were thriving in their healing process. And in that, the hope that I found is really what propelled me early on in my recovery. It was this new spark that I hadn't felt for quite some time in my life. And to realize that healing was possible was this contagious realization that had a tremendous impact on my trajectory in my life and my healing process. So organizations that implement or thrive on a ROSC and a recovery-oriented system of care, they get that. They understand that. They believe, more than they get that, they believe that recovery and healing is possible. And that individuals, they really do possess what they need internally in order to heal. Sometimes we just need people to believe in us until we're at a point where we can start to believe in ourselves again. In a ROSC recovery supported by peers and allies. So even if you don't have that direct lived experience yourself, allies play huge integral roles in our healing process. And recovery involved or rejoining and rebuilding a life in the community. So ideally, treatment, crisis services are temporary things in a very long continuum of recovery of a life of healing. At some point, we need to be able to reintegrate into our community, and what better way than to just have our community involved in our treatment and healing process from the very beginning, which I think the living room model and Schenectady has done really well. Okay, so I've talked to you about this resource. I've talked to you about ROSC and centering lived experience and the value of doing that, and the value of uplifting peers. But how do you gauge where your organization is at now, and how much work it needs to do in order to really move towards that recovery conscious organization framework? There are two tools in this resource I keep talking about. One of the tools is a very brief yes or no questionnaire. You can look at them now on the screen and maybe ask yourself internally some of these questions. Part one, is your organization recovery oriented at all? Is the organization focused on participant defined life goals, or is it focused on those treatment plan objectives that are sometimes set by the clinician rather than the individual? Part two asks about the commitment to effective peer employment. Is there a nuanced understanding of the peer ethos, values, and history? Does everyone within your organization understand the role? Going back to those issues that I said a few slides above about the barriers that peers face, one of the largest issues peers face is a lack of role clarity. So if you want to move into a very recovery conscious organization to grow your organization's recovery consciousness, everybody needs to understand the role of peers, have a clear understanding and delineation of that role from other roles as well. An additional tool within the same resource I'm talking about, the second tool in there, is an organizational assessment on recovery consciousness. So this tool has 7 domains, and it has questions that you can fill out yourself. You can have many staff members, ideally at different levels of the hierarchy within your organization, fill out this questionnaire, and you can gain a score of how recovery conscious is your organization. Maybe you have a really high scoring domain 1, but you're struggling in domain 7, supporting authentic peer work. I really encourage you all to, if nothing else, after my portion of this webinar, is to get this resource, take it back to your organization, and to fill it out. Because if you should find that your organization scores low, maybe in all 7, maybe in just one of these domains, then you are able to get some free technical assistance from the Peer Recovery Center of Excellence, which the National Council for Mental Wellbeing is a part of. So if you find yourself scoring low and you want to learn more about how to integrate this concept of recovery consciousness, or how just to better support peer workers in your crisis organization, you can submit a request through the Peer Center of Excellence, as you'll see on this next slide. We have 5 core focus areas within the Peer Center of Excellence. At the National Council, we are this first core. We work on integrating peers into non-peer, non-traditional settings. So that can be in clinical settings, that can be in CCBHCs, most likely in the organizations that you all work for. If you need any additional advice, guidance, or support, please don't hesitate to reach out. That is what we are here to do. Additional support that you can receive from the Peer Center of Excellence is recovery community organization capacity building. So if you work with an RCO or you partner with an RCO, they could receive support through the Peer Center of Excellence. Peer workforce development. So if you have peers and you need specific training for them to, let's say, move towards certification or credentialing in your state, you can receive some TA there. Evidence-based practice and practice-based evidence dissemination and diversity, equity, and inclusion work. That's our newest core team at the Peer Center of Excellence. But it's on the next slide, I'll have a link of how you can access that TA. You would go to peerrecoverynow.org. And I'll just, I guess, wrap up with thanking you all again for the work that you do. Understanding that just as recovery and healing falls on a continuum, so does learning to integrate peers and understanding peers and moving into a recovery conscious organization. It starts with making a decision that you want to change, you want to grow your organization, and then starts with just a few small steps, and you can move yourself towards a really recovery oriented system and organization that uplifts the peer voice, the peer experience, and helps individuals in their healing process. And I think with that, I'll turn it over to Alyssa and Lynn to talk a little bit more about their work that they're doing in Schenectady in the living room.
Thank you so much, Courtney. Thank you to the National Council for Mental Wellbeing for inviting us today, as well as the support from Ellis Medicine and our whole team here. We really couldn't do it without you. And I'm just gonna briefly introduce myself and say my name's Alyssa Starantino. I'm the psychiatric supervisor of the Ellis Living Room program. I'm also a licensed clinical social worker. I've been in the field for a little over 10 years now, and my background is working with adults with severe and persistent mental illness, as well as teenagers living in a residential treatment setting locally, and have been in my current role for the last 2.5 years, getting the privilege to support the clients in our community, as well as the staff that we work with.
Hello, my name is Lynn Adams, and I am a peer support specialist. And I've been working in the health field as well, in many various settings. And not only that, but I've been dealing with mental health for the longest time, for maybe over 20 years of my life. So I clearly understand the depths of the battles and the struggles that is out there today. And I will later on discuss that. And I just now became a peer last year in October, and it is a blessing and a calling on my life.
So Lynn and I are going to outline for you what outpatient crisis diversion model is. We'll talk about the history of the living room model in brief, as well as go over what our program entails, what a day would look like, a visit to our program, as well as measurements of success related to our last 6 years that we've been in the community here in Schenectady. So first, we would like to discuss what outpatient crisis diversion is. Next slide, please. I don't have the access to change the slides. If someone could change, okay, there we go. Great, thank you. All right, so outpatient crisis diversion. It's a model of crisis diversion that is proactive in nature, offering screening and assessments at an outpatient level to those who are in mental health crisis, as opposed to an emergency room hospital setting. And it still operates at the same function of being able to provide stabilization services to keep individuals both safe and hopefully be able to leave the program that day, returning to a stable life in the community. And the goal of the outpatient crisis diversion model is to decrease the overutilization of emergency room resources. And we feel that the crisis diversion model is so important because it can decrease the likelihood of harm to the individual who's presenting in crisis, as well as others who are at risk of that harm by the one that is in crisis. It can also potentially prevent services such as emergency responders, law enforcement, and emergency departments from becoming involved by having an early intervention approach to the crisis at the outpatient level, and potentially also de-escalating the crisis by not having more people involved that could be triggering for the individual who's going through the crisis. By doing an outpatient model that is timely in nature, we can prevent the need for the crisis to escalate to where hospitalization is needed, such as at an inpatient psychiatric hospital. And as a result of not having as many resources involved because of treating at the outpatient level, there hopefully should be savings over time, from the prevention of the crisis from escalating to a higher level. And the goals of having a crisis diversion model is to make sure that the individual who is experiencing the crisis is heard, that they are being provided empathy, supportive listening, and to be able to stabilize them so that their symptoms that they are coming in with are reduced by the time that they leave. But we don't want to just stop with that. Of course, we want to be able to prevent further crises from arising by problem solving with the individual who is presenting in crisis and be able to help provide them with coping skills and next steps for their journey, including referrals through a warm handoff process so that they can get linked to long-term care services if desired. And what we believe the living room model is offering is a ability to redefine what crisis intervention looks like. We have been not the first model, but this has been a relatively new conceptualization within the last 11 years. The first living room program was founded in Illinois in 2013. There were studies done in the late 2010s or early 2010s showing that individuals who were presenting to the emergency room in crisis were desiring to have a safe place to go that wasn't a hospital setting where they could talk to individuals who could support and understand them in a home-like environment, and be able to be heard and leave feeling like that there are tangible next steps that they can take without feeling re-triggered in their crisis based on the environment that they were in. And so the cornerstone of the living room model, as was then and is true for our program, is that we serve adults 18 years and older. For anyone who's experiencing mental health crisis, they do not have to have a mental health diagnosis. Insurance is not required. The first program was grant funded, and we have also, as I will explain in a minute, heavily relied on grant funding so that we could be an inclusive model that we really believe in not turning anyone away who is experiencing a crisis, so that we are really breaking down those barriers so that all individuals facing mental health issues can be served. And the living room is, you'll see a virtual tour from Lene later on, is a very comfortable, calm place, and is that alternative to an ER. It's not clinical or sterile. It's very home-like in nature and comfortable for folks. And you'll hear me talk about the 3 prongs of what the living room model is. There's the supportive therapy that's provided both by social workers and peer counselors. There's the care management services that help address the structural or systemic issues that someone might be coming in with. And also, of course, is Courtney first detailed, that peer recovery, peer support model. And I just want to detail a little bit about what it was like to get to the living room today. So we've been in operation since 2018. We're here in Schenectady, under Ellis Medicine, under the Ellis Mental Health Services umbrella. And we have been working with other partners in the community for quite some time to see how to best address the growing mental health need in our community. So one of the prime areas where it was explored that mental health needs needed to be greater met was looking at the Ellis emergency room that was being highly utilized for mental health crises. And Ellis took a look at this along with a community partner, Rehabilitation Support Services, which is a local care management agency. And in 2018, they found some space in our new building within the Ellis Mental Health Services location here on 1023 State Street in Schenectady, and founded the first living room program in the region. And we were able to secure grant funding through the Ellis Foundation, who's been instrumental in helping us keep the doors open. We have support. We had support early on by Social Service Agency, Healthy Alliance, charitable organization Mother Cabrini, and CDPHP, who's been a big supporter of us throughout. And from there, we were able to recruit our staff. We were able to hire internally a social worker for the program, as well as a care manager and a peer counselor. And from there, we were able to grow because we've really shown to meet a need in the community. And that looks like today we have 2 social workers on staff, myself included, and another full-time social worker. We have 4 part-time peer counselors who are able to provide their lived experiences to meet the needs of the individuals coming in. And we also have a full-time care manager, and we'll certainly get into each of those roles a little bit later on as well. So we are continuing to grow and innovate, and we've also provided 2 new groups as of this past year. We have an art group that meets weekly, and we also introduced a gardening group because we really do believe in crisis intervention as being holistic in nature, that the more support and connection that you have, the less likely crises will arise. Or if they do, you'll have the support to be able to get through them more easily. And Lene is going to talk to us a little bit about what a visit to the living room looks like.
Yes, so when the guest comes to the living room, they will first be interacted with the guest, the peer specialist. And the peer specialist will then introduce themselves, and then the guests will express their needs and concerns to the peer specialist. Then after that, the peer specialist will check them in and do a full assessment. The full assessment includes personal and contact information, SUD scores, which is subjective units of distress. Safety measures would be assessed, such as homicide ideation, suicide ideation, substance abuse, domestic violence relations. Other factors will include social support, such as friends, families, and a valid health team and provider. Other things that we look for in the assessment is strengths and weaknesses. And the living room is well capable and equipped to provide and support comprehensive crisis counseling on every level. And when the crisis or the concern or need is high, then the social worker will further address and assess that concern with the guests. Other resources that we have at the living room is that if the guest is lacking housing, employment, having financial difficulties, need help with transportation, then the care manager will assist with the guests and address those needs with the guests and make referrals as needed. And as I stated previously, the peer specialist will introduce themselves to the guests. The guests will hear the needs of the guests and check them in and do an assessment. Within that session, the peers are encouraged to share their life experiences that they have personally, their struggles, their battles that they have struggled with throughout life, to give the guests hope, to let the guests know that there's somebody that understands them and can identify with their struggles and battles that they go through every day. The guest is encouraged to assist them in developing coping skills. What works best for the guests, to help them deflect from negativity, racing thoughts, overwhelming experiences and emotional disturbances that they don't understand or can't point out. The peer is also will assist in conflicts and distress concerning the guest. It takes a mature peer to understand about life and the trials that life bring, to help the guests navigate through complex situations that seem very troubling, and situations that they have no control over, to give them a positive and effective direction and problem solving, to help them independently make choices that works best for them, to help them feel a self of worth and empowerment, to know that I can reason, I can think, I can accomplish, I can overcome. And not only that, but these are the things that help them in their present. And that, and the peer helping them in their present will help them see that they can have a stabilizing success in their future and reaching their goal, which is coming to the point of their recovery. So speaking of me, I understand the struggle. I understand going through that battle. I once was a client of the Living Room in Schenectady, New York. And they gave me a listening ear. They were very helpful. They were very in tune and sensitive to my pain and to my hurt. I once was that young woman for over 20 years of my life that went through PTSD, trauma, distress, anxiety, depression, bipolar, you name it. I went through it all. And giving myself that voice to be heard and not allowing my mental health to shut me down and to keep me silent gave me a career pathway. Because by me opening up to my pain, it was able to help others, and others could see that, wow, I'm not in this alone, and I do have hope. And if that one person can overcome, so can I. And I saw that this was working by telling my testimony, and this became my purpose and my mission. So what I did is I turned my pain to my story to become my testimony, and I turned my testimony to my passion. And I saw a calling to help people out of their struggle, to help people through their battles that they go through every day, because it's very real out there. And I became an advocate for people that can't put their pain into words, that don't know how to express their need, that don't know how to say or pinpoint what the root of what they're going through. And there was a case where this woman, her guardian had her in a situation where she was in a sex trafficking situation, where she was selling her body for her guardian to make money and for them to live and be able to pay their bills. And not only that, but it was self-destroying her. And she felt some sense of worth and was so immune to being raised up in that environment to feel needed and have that attention. And I talked to her and I said, and I got to the root of her answer. And her thing was fear. How do I live when I come out of my captivity? How do I survive in what I'm no longer common to, or what I'm no longer used to, when I've been raised up on this dark side of my life, all my life? How do I live in my victory? How do I live being empowered? And so it was fear, because fear in reaching at the point of your recovery can be very challenging and an awkward experience. And just coming from that complicated case, my co-workers at the Living Room was able to help me to overcome that session. and to help me to reevaluate what was said, and to just to bring me back to myself. Because as a peer, and as we encounter different cases, and such cases that can be complex and difficult, can have a toll on you mentally and emotionally. And my teammates at the living room was able to help me with that I could be able to rejuvenate and further continue on and serve in my community.
And I just want to add that working with Lene is such an inspiring, heartfelt process, if you couldn't already tell. And her story is so impactful, and stories like Courtney's, that people heal from each other's stories and the lived experiences that they bring forth into the work, this calling that we do. And so we added the quote, "We are the living room," because we want to break down the barriers, the power dynamics that exist in the medical model, to really see and hear the folks that come in to see us as fellow human beings in this healing journey. So it's a privilege and an honor to get to work with Lene on a daily basis as we bear witness to this journey together. And so with the peer, there's a really in-depth, intertwined experience that happens when we have each of the pillars that I talked about before: the social worker, the peer, the care manager, working together as a team. And I wanted to talk a little bit more about the social worker role, which is, again, myself, and we have one other social worker on staff, that we're able to provide more in-depth crisis counseling in those situations when someone's presenting with complex crises or multiple mental health disorders that may be beyond the scope of an initial assessment that is done for them. That allows for us to do some safety assessment planning if needed, as well as collaborating with other treatment providers, making sure those lines of communication are open, and initiating plans for referral. And if needed, we can coordinate a crisis evaluation by sending an individual to the hospital. And as we'll get into, that is something that is very rare that we have to do that, but in terms of making sure that there is that safety piece that's being met, we are able to use some of the scaling of the Columbia assessment, as well as the chronological assessment for suicide events, to be able to make sure that individuals that are coming into us to see us are first and foremost safe, and that our community is safe. And additional to the social work services, we also have our care manager on staff. And each time someone comes in, we're really trying to assess if there are other areas of their life, their living situation, food, housing, where there is inadequate resources available to them. The first time someone comes in to see us, and as Lene had mentioned, that assessment gets completed, there's the social determinant of health screening, which is a pretty standardized tool that's used to be able to determine if someone is in need of care management resources. So questions such as, does someone have access to their prescriptions? Do they have a place to stay tonight? Are they in need of food at home? Help us to understand and work with the individual coming in to determine if they would like a long-term care management referral, which we can initiate on our end. And in the meantime, provide that stopgap where they can get services from our care manager to help with benefit paperwork, obtaining other resources such as information on local food pantries, initiating other referrals, getting connected to legal help until they get into long-term care management or other long-term services. And so before Lene gives us a nice virtual tour of the program, the care manager, social worker, and peer counselor work very closely together, and we are able to sometimes have multiple people in the room at the same time, which provides a more in-depth lens and perspective on the case that of the client that's coming in. and to be able to consult with each other and really not just use the resources within the living room, but within Ellis Mental Health Services as a whole, that from the leadership on down, we really prioritize collaboration and synthesizing the resources that we have available to best come up with a cohesive treatment plan for the individual coming in so that they are left fully equipped for the next stage in their journey. So Lene, take it away with a little tour of our program.
So here we are at the living room, and this is the waiting area where people can reflect and kind of gather their thoughts on how they want to express their needs and concerns. This is the den where people can feel vulnerable, and it's a safe place where they can feel comfortable to be able to easily feel that vulnerability to express whatever their crisis may be to the peer. And the meditation and relaxation room is where they can put their feet up. Again, feel that vulnerability, that home setting, to get away from that office type of feel, but to feel at home and to feel that they can gather their thoughts, be at peace, where they can feel, again, at that safe place to talk about their concerns with the peers. And the meditation room, we also have we can dim the lights. We have a media, a TV where they can have meditation music, nature sounds. Sometimes the guests, they don't want to talk. They just want to sit. They just want to reflect. And this is a room for that they can do that if they just want to sit in and get themselves to a place of peace. And the kitchen and the art room is where they can be creative. Some people don't know how to voice out what is bothering them, and they can journal. They can color their feelings. They can relax with coffee, and we would give them a snack. And these are coping ways to deflect from the negativity and overwhelming emotional feelings.
Thanks for the tour, Lene. So I wanted to just reiterate the impact of the living room model by illustrating a case with a client that is well known to us. She's someone who moved here from out of county, was homeless, and had no supports in the local community, no providers when she first came and saw us. And then over a period of several visits, our care manager got her connected to a referral for mental health treatment, got her services moved up here, had her connected to long-term care management, and started to get her working on getting other benefits in place. But more importantly, she started to see a beacon of hope. She started attending our art group that started in November, making sure to diligently attend weekly. And we started to see this woman have a spark in her eyes. She has told us that the art group is the highlight of her life, that the living room has made her into a new woman, where she is able to have positivity and gratitude in her life. And she calls the staff that are basically her angels that help watch out for her and help keep her safe and making smart decisions in her life. And we've seen just how that support and the consistency, when whoever it may be, to have human beings that you can go to when you're having a hard day and know that despite whatever environment that you're in, as chaotic as it might be, if you have someone that you can go to as a touchstone of peace, of healing and support, that there is that ability, there's that light towards wellness. And so, you know, she's someone who's really emulating that recovery model of making meaning of the trauma of her past to empower her to move forward to having a better life, and one that is mutually inspiring to us as the staff at the living room. And that's just one of many cases of people that have come through that really, and I would say for all of you that I see posting in our chat here from your own services, some of which are from other living room programs, that never minimize the impact that you make on the individuals that you serve. And really, we believe that we are redefining crisis intervention through this approach based on the recovery model that Courtney talked about and on peer services. And Lene is going to talk a little bit more about some of those barriers that we're helping to break down as a result of our programming.
Yes, so we understand the history of mental health. The history of mental health has people lacked understanding. There was not enough education on it. The bias, the judgment, the discrimination, the human experiences, the poor medical practices, the neglect, the abuse has caused people to lose lives because of the misunderstanding of mental health. But the living room is redefining that crisis intervention by reducing barriers to access to behavioral health care. And how we're doing that, because we're eliminating the bias, we're eliminating the judgment, we're eliminating the discrimination, and we're not basing on what people have or don't have, such as insurance, the paid medical costs, co-pays. They can walk in without no appointments necessary. They have access to providers that we're partner with to give them and address their needs and concerns in everyday life. And not only that, we're redefining crisis by a team-based approach, because the living room is unified and we're on one accord and we care about our community, and everybody works collectively and adds to that to make what we do and our services effective. And this comes into early intervention because people don't need to go to the ER. They don't need to fill up the hospitals, and we can provide those same resources that our community is lacking. And that what makes us accessible, tangible, and reachable, because we're proactive in what we do to bring about a necessary change in our community.
And looking ahead, and as well as where we're coming from, we want to continue to decrease utilization of the emergency room for mental health crises, so that individuals can stay in the community and have that support as closely as possible to what they are used to in their day-to-day lives, and to be able to develop that sustainability and streamline care for folks by addressing the root causes of crises, helping to link them to services as soon as possible using that early intervention approach. We want to continue to reduce healthcare costs related to overutilization of services, and change how we look at getting care, from having to fail up the ladder where no appointments are available, or there's insurance barriers which lead to someone having to escalate their crisis to presenting to the emergency room, to one that is a more proactive approach. And also there's that emphasis on individuals who tend to be high utilizers of the ER to figure out what some of those needs are that aren't getting met, to help reduce recidivism and improve quality of service for mental health for all, especially those who are at risk or vulnerable to mental health crises, so that anyone that walks through the door, we can help partner with them so that they can return to a stable life in the community. And for those of you that are intrigued by the model, maybe thinking about adopting the model in your own community, just some detail about what has been proven to be cornerstones that have worked for our model to be successful. One, we've had a steady stream of referrals from the emergency room, being able to redirect them to us so that we can start working with them to come up with an approach to how to better address what they're going through. And we also partner with local providers such as primary care providers, other agencies, substance abuse treatment agencies, and get referrals from them. And a lot of these referrals are two-way basis, that we also are providing linkages with individuals to resources that the community providers are offering as well. And the collaboration is really huge because we are able to get take a temperature on what is happening in the community, what the nature of crises are, whether it's the opioid crisis or housing, or what some of the patterns are in the community, and work as a team together. I feel like this is something that Schenectady really strives to do and often does effectively, is working together to problem solve on these issues and be a part of the solution. And we also are really working to demonstrate the indispensability of our services by showing that we are saving money to funders, including insurance companies, and that, as you'll see in our stats, that we continue to be highly utilized by the community. And from a programmatic perspective, retaining staff and making sure that they are taking care of themselves, feeling that support, really starts from top down, from the Ellis leadership. And they, my supervising staff really provides a caring, non-judgmental model, one of creativity and collaboration. And that's something that I and the rest of the team try to emulate in our work with each other, so that we aren't operating from a crisis mindset ourselves when we're doing this work with the clients coming in, that we're able to co-regulate together so that we can hopefully then instill that in the clients that are coming in. And part of that too is having that team-based approach. We're all trained in safety and crisis prevention models, including the CPI model, which is something that Ellis provides, that help us to know when we might have to tap out or bring in another team member or bring in the social worker, so that everyone, including the staff, are feeling safe and comfortable. And the foundation or bedrock of our model is being able to have policies that support the work that we do and the safety of the clients and staff, clear communication from leadership on down through to the clients and community providers, and clear role and expectations on what it is that we're doing, as well as making sure that staff are receiving regular trainings. Our peers receive training through Certified Peer Academy, and we have other trainings through Ellis and in services to make sure that we're staying up to date on current best practices and supporting the clients. And I'll just quickly go over some stats for all of you. So I just have up the last few years. Again, we've been open since 2018, and we've been serving each year between 900 and a little over 1,100 people a year. And I'll say for 2024, for the first 5 months of the year, we've already served over 600 clients. So we are well on our way, most likely, to breaking the record for each of the last 3 years for how many clients are coming in. And we're consistently getting referrals for new guests as well. As you can see, somewhere between 430 and 490 new individuals are being served each year. And we're really keeping the ER visits, the having to send someone to the hospital from our program really low. Only 2% of individuals on average are being sent to the hospital. And that is in reference to the original Illinois model, which their first year they had a 93% diversion rate, which is still very good. And we've decreased that margin to one that's just a 2% rate on average. And as a result, by diverting the need to utilize the ambulance services, have a crisis eval at the emergency room, we're on average saving around 2 million plus a year for preventing costs to for healthcare for the clients and for insurance companies and hospitals as well as taxpayers. And we also, again, with that long-term focus of getting people connected with care, we're getting people into mental health services on a consistent basis, over 300 linkages, and I think it's probably even higher than that, getting people linked to mental health services as well as other necessary resources in the community. And Lene is going to take it on home with the big high impact stats with regards to what our program has accomplished over time.
So quickly, between 2018 and 2024, the living room has had a 98% crisis diversion from the emergency department. And in savings, the living room has saved in New York State and Schenectady County $7.1 million in savings, and our impact because of 98% crisis diversion and 7.1 million in savings, we have had an impact on our in the living room with clientele 4,700 people, and I believe it's 2,000 referrals has been made because of the living room. And this is what makes the living room powerful and successful as it is, because we are who we are and we say what we believe and we do what we mean. And that's what makes the living room successful.
Thanks, Lene. And we wanted to share too that with the cost saving measures that this has helped. $7.1 million is reducing costs for those who are utilizing our services and who may otherwise not be able to get the mental health care that they need. And before we go on to the Q&A portion that Matt is going to facilitate, I just wanted to add as an epilogue that Ellis has worked over the past 9 months to open up a brand new program called the Family Room Program, which serves children and adolescents from 11 to 17. And has been successfully working with clients these last 4 months that it's been open. So maybe we'll get to come back a second time and talk a little bit more about that model, but just wanted to leave that off as something that's more to come that we're very excited about. And I want to thank you all again for having Lene and I here, and happy to turn that now over to Matt for that Q&A portion.
Yeah, thank you, Alyssa, and thank you to all of our presenters. Thank you to Lynn and Courtney for sharing your stories, and thank you to Nashville for all of the support in putting on this webinar, and SAMHSA as well. So what a passionate chat today. There were questions coming in. I've tried to keep track of as many as I could. If there were themes, because we only have 15 minutes, I'm going to try to lump them together so we can kind of maybe broadly answer questions. But So going back a little bit, Courtney, to your piece, well, actually, more broadly to the panel, when we talk about recovery, are we talking about mental health or substance use or both?
I'll answer for myself. I was referring to both, really, and I believe at the living room, you'll see both, but majority of individuals who are struggling with substance use disorder are also struggling with mental health challenges. So for everything I was referring to, the resources provided, it can cover both.
Lene or Alyssa, you agree? Is that the same for you?
Absolutely. We definitely see a lot of the dual diagnosis population. Certainly there can be one or the other, but we partner with a lot of substance abuse agencies as well to address the needs of folks that may present with both to our program.
Okay. And Courtney, this one was free. This is the one I was talking about for you. I told you there were lots of questions. I was trying to keep my list organized, but so can you talk a little, Courtney, more about some of the evaluation tools that are located in that SAMHSA COE resource you were talking about that just came out?
Sure. So there's two real assessment tools. One is a 2-part questionnaire with only a few yes or no questions built right into it. And then the longer, more extensive tool, I think it's located on page 25, if I remember correctly, of that resource that's dropped quite a few times in the chat now. And that is a more extensive questionnaire for covering 7 different domains. But it should be, they're both within the same resource at that URL link.
Okay, wonderful. And again, we encourage everybody to take a look at that and everything else that the peer COE through SAMHSA has to offer at the website. That is both in the deck and that I dropped in the chat up towards the beginning. Okay. Lene and Alyssa, we had quite a few folks asking about some like what I'll call more like operational questions about the program. So I'm going to ask kind of a few so I don't pepper you with a bunch, but what are your hours for the living room?
Thank you. We're open 10 a.m. to 6 p.m. Monday through Friday.
And how many guests can you serve in a day?
We as I mentioned before, we have a lot of support and collaboration within the departments of our building. So I would say on average we are able to accommodate the client flow that has been coming in, and what that looks like, it could be anywhere from 3 or 4 clients a day to up to 12 to 15.
And what's the average length of stay? And average is, you know, I know average is a broad term.
Yeah, so that we take that statistic on a monthly basis. So it usually ranges between 60 and 80 minutes.
Okay. And how many living rooms are there in New York State, if you know? Shelley asked that question.
I have heard of that there was a living room potentially downstate in Poughkeepsie area that was more substance abuse focused. That's the only one that I'm aware of besides ours. And so in terms of ours having that unique mental health focus with also the social worker and peer counseling component, I think that this is the only model that's common in the state. But I would be happy to be corrected because I think we need more of our programs out there.
Yeah, well, and in the chat, we definitely saw folks who said, I'm really interested and expand. This is a really innovative model, interesting. So hopefully we see more pop up. In each of these settings, do you know how many peers are certified peer specialists? David asked that question.
In each of, in our particular setting?
Yeah, in the program.
Yes. Okay. So we have, we currently have 4 peers, one who's just going to be starting with us, and 2 of them are peer certified, and one of them is working on their certification.
Okay, excellent. Mallory had a question again about kind of, this is like, model is interesting because it's kind of like an interdisciplinary team of folks. You have the social workers and the case managers and the peer supporters. So Can you talk a little bit about, and maybe like differentiate between the peer support role in your program versus the case manager role? Mallory had that question.
Sure. Lene, do you want to take that one or do you want me to?
Well, the peer will first deal with the mental health need and address that with the guests. The care manager will help basically, their role is to help with the additional resources like, housing, as I said again, transportation. If the person needs counseling, med management, difficulty financially, the care manager will be helping those and further assessing in that need for the guests.
Excellent. Okay. And then we had a question about, again, this model is a little bit, it's innovative because there's that interdisciplinary approach. Can you talk a little bit about how you perhaps align the model with recovery, given that it's kind of its own innovative model, some of the principles that Courtney was talking about earlier, and just kind of the overall approach of being recovery oriented?
Yeah, absolutely. I think that by basing the foundation of our program on the peer counselors and their lived experiences, that there is that emphasis on creating meaning out of those experiences that like our staff have gone through, and sharing some of those lived experiences in appropriate professional ways to show that there is that rehabilitation that can occur to someone when clients are coming in and they're hearing that the individual that's sitting in front of them who has gone through the same experiences that they have, it helps to put the recovery model at the forefront, that this is something that is possible for them. And Lene, do you have anything that you want to add to that?
No, peers are just encouraged to people like authenticity, be authentic. That's the word I want to use. And they like honesty. They like to see that the guests, that the peers are sensitive, that they understand, can identify with their struggle, because the struggle is real. It's more than just a role. It's more than just what I'm educated in, but can you identify with my pain? Can you identify with my hurt? Do you understand the root of my fight? And can you answer that? Can you come up with a solution? And people want an answer, and they look to us to give them that answer and to get to the root of their problem so they can move on and move forward and not feel stuck in their own captivity.
Wonderful. And building off of that, there were a lot of questions about kind of how do the services work together? How do the peers and the case managers and the social workers work together? Could you talk maybe broadly about at the program, how does that interdisciplinary team work together to kind of assess, reassess, and meet the needs of those coming in?
So we have an individual who works as our greeter, who is able to be aware of when a client comes in to our program initially, what staff is available, and is it someone who's coming to us for the first time, and so likely they're being connected with the peer counselor to do that initial assessment. Is it someone who's presenting with symptoms that are more escalated, so perhaps the social worker gets involved, or is it more of a urgent care management related case, such as their presenting need is that they're homeless and they don't have a place to stay for tonight? So that triaging happens right off the bat. And then usually I come in as sort of that quarterback or team captain that I'll get a staff coming in and consulting with me regarding what services does this individual need. And so an individual may end up working with multiple staff during the visit, doing a warm handoff between the peer and the care manager. All of our offices, you can't really tell from the tour, but they're very close together. So there's a lot of consulting and collaborating that's happening. And so they may meet with 2 or 3 staff during the course of a visit.
Oh, that's really interesting. So it may be even kind of like a team that meets them right at first to kind of assess how they're doing?
Yeah, it absolutely can be. Sometimes it's the peer counselor and the social worker going in together, or the peer and the care manager. Sometimes it starts with just one of them, and then they switch out as more guests come in, and making sure that people are being seen in a timely manner. So again, that's where I come in, so that we can help juggle the needs of the folks that are coming in and make sure that people are receiving care in a timely manner and in a thorough one as well.
Mhm. And one more before we let our folks go. Is there a limit for how frequently guests can come in?
No, no, but we've certainly worked to problem solve, again, through a person-centered approach. What is the need that's being met if someone is coming in frequently? And I've talked with some of our clients coming in that we need to expand their resources from only having a crisis program to be their only resource. And so what would that look like? What are some of the fears that come about when talking about connectivity to other resources, or utilizing those, or developing peer connections? So we're willing to have those in-depth conversations and see, can we shift maybe some of that utilization so that they're having a more holistic reach in terms of other resources that may avail themselves.
Wonderful. And then since you mentioned housing, we have one more minute. How do you help support housing? Because that is a issue that the health providers encounter all the time.
Absolutely. And I wish I could say that we have some holy grail solution to that. We don't, but we do have a pretty cool partnership with Rehabilitation Support Services. They have a program called the SOS program that is specifically tailored to do street outreach and get referrals from community providers for those who are specifically homeless. And they can go out in the community, do street outreach, take individuals to Department of Social Services, have a thorough sweep of housing that's available, do some of those applications. And those are some services we offer as well. While we are pretty stationary within our program, we can do housing applications. We certainly refer people to Department of Social Services. We can write and obtain records from Department of Social Services, coordinate appointments, and then certainly link people into long-term care management. So we do the best we can. It's just a lot of the time, it's not overnight solutions, but we try to instill hope in the meantime with folks till they can get connected.
Wonderful. Well, I'll be respectful of everybody's time. I'm going to toss it back to Nashville to close us out. And thank you everyone for coming today, and thank you again to our presenters.
And I just wanted to add, if anyone has any questions, if they are interested in building a model, the living room program in their community, I'm more than happy to be reached out to. I know that the slides are being sent out, my emails and the slides, and so is Lynette. So pardon me for that last announcement, but definitely passionate about the model and expanding it.
Fantastic. Well, thank you all so much for this wonderful presentation. This does conclude today's session, and you may now disconnect.